Chapter 2, Vocabulary. Actinic, relating to or exhibiting chemical changes produced by radiant energy, especially visible and ultraviolet parts of the spectrum relating to exposure to ultraviolet rays or sunlight. Angiogenesis, the formation and differentiation of blood vessels. Atrophy, the decrease in size or function of a cell, tissue, organ, or whole body. Chemotaxis, the movement of white blood cells as directed by biochemical mediators to an injured area. C-reactive protein, a non-specific protein produced in the liver that becomes elevated during episodes of acute inflammation or inactivity. Cytolysis, the destruction or dissolution of a cell. Emigration, the passage of white blood cells through the walls of small blood vessels and into injured tissue. Epithelialization, the process of being covered with epithelium. Fibroplasia, the formation of fibrous tissue as normally occurs in healing. Fistula, an abnormal passage that leads from an abscess to the body's surface. Granulation tissue, the initial connective tissue formed in healing. Granuloma, the collection of macrophages usually surrounded by a rim of lymphocytes. Hyperemia, an excess of blood within blood vessels in a part of the body. Leukocytosis, the temporary increase in the number of white blood cells circulating in the blood. Lymphadenopathy, abnormal enlargement of the lymph nodes. Macrophage, the second type of white blood cell that arrives at the site of injury. It participates in phagocytosis during inflammation and continues to be active in the immune response. Margination, the process during inflammation in which white blood cells tend to move towards the periphery of the blood vessels at the site of injury. Microcirculation, small blood vessels including arterioles, capillaries, and venules. Myofibroblast, a fibroblast that has some characteristics of smooth muscle cells such as the ability to contract. Neutrophil, the first white blood cell to arrive at the site of injury, the primary cell involved in acute inflammation. Opacification, the process of becoming opaque. Opsonization, the enhancement of phagocytosis by a process in which a pathogen is marked with an opsonin for destruction by a phagocyte. Pavementing, the adherence of white blood cells to blood vessels during inflammation. Purulent, the secretion containing or forming pus. Radicular, pertaining to the root of the tooth. Serous, a secretion having a watery consistency related to serum. Transudate, the fluid component of blood that normally passes through the epithelial cell wall of the microcirculation. Wallier's ring, the ring of lymphatic tissue formed by the two palatine tonsils, the pharyngeal tonsil, the lingual tonsil, and intervening lymphoid tissue. Localized signs of inflammation include redness and heat, swelling, pain, and loss of normal tissue function. The systemic signs of inflammation include fever, leukocytosis, lymphadenopathy, and elevated C-reactive proteins. Types of repair. Healing by primary intention. Healing by primary intention refers to the healing of an injury in which little loss of tissue takes place, such as in a surgical incision. Healing by secondary intention, however, occurs when lots of tissue is lost. Thus, the edges of the injury cannot be joined during healing. A large clot slowly forms, resulting in increased formations of granulation tissue. Healing of a tooth extraction site is an example of healing by secondary intention. Healing by tertiary intention. If infection occurs at the site of a surgical incision that is healing by primary intention, healing by tertiary intention may result. This transformation occurs because of an enlargement of the injured area and an increase in the magnitude and duration of the inflammatory and immune response triggered by the presence of pathogenic microorganisms. In some cases, an infected injury is left open and the edges are not surgically joined until the infection is controlled. Lesions from self-induced injury. Traumatic ulcer. The traumatic ulcer occurs as a result of some form of trauma. The trauma can vary, but usually it involves some sort of biting of the mucosa, the tongue, and or some sort of hard object that can puncture the gingiva. The appearance clinically, it looks like a red ulcerated area. Usually it's more erythemic than the rest of the tissue. It also has a white border in some areas. And it usually heals between 7 to 14 days. If not, a biopsy might be needed to rule out other diseases such as cancer. Frictional keratinosis is caused by chronic friction against mucosal surfaces. It's found at the site of friction, and it's characterized by white mucosal surfaces that have become hyperkeratinized. Nicotine stomatitis is caused by smoking. Its location is the hard palate, and its clinical features include white opacification of the palatal mucosa with raised red dots. Smokeless tobacco-associated keratinosis is caused by chewing tobacco. Its location is the site where the tobacco is usually placed, and it appears granular and white, wrinkled in appearance. Traumatic neuroma is caused by injury to the peripheral nerve. Its location is the site of the injured nerve, and its clinical features include painful submucosal nodules. Its treatment and management is surgical removal of the nodule. Melanosis, which can be caused by smoking or trauma, appear clinically as diffuse grayish-brown color of areas of the gingiva. They are localized molecules of pigmentation. These areas fade with decreased smoking. Solar colitis is caused by sun exposure on the vermilion of lips in adults. Clinically, it looks indistinct and fissured skin mucosal interface, and the way you can prevent this from happening or to treat it is by protecting your lips with chapstick that have FPS. A mucocele is caused by a severed salivary gland duct. It can occur at any age and is mostly found on the lower lip. Its clinical features include localized tissue swelling that increases or decreases in size. Its treatment is surgical removal, or it might just resolve on its own. A ranula is an obstruction of the salivary gland duct. It's located on the floor of the mouth, and it's characterized by a fluid-filled swelling that increases or decreases in size. Its only treatment method is surgery. A sialolith is caused by the precipitation of calcified material around a center core. Its location is the major and minor salivary glands, and clinically, it's an obstruction of the gland, and it appears as a hard nodule in soft tissue. Its treatment is surgical removal of the stone. On a radiograph, it appears as a radio-opaque structure. Necrotizing sialometaplasia is caused by compromised blood supply to the area of the body. Its most common location is the junction of the hard and soft palate, and its acute onset is characterized by moderate painful swelling and ulceration. There is no treatment method, and it will spontaneously resolve. Sialodentitis is caused by infection or obstruction of the salivary gland duct. Its location is only symptomatic when involving major salivary glands. Its painful swelling of the gland is often treated with antibiotics if infected. Reactive connective tissue hyperplasia, pyrogenic granuloma. These can be caused by response to injury, puberty, or pregnancy. It is most commonly found on the gingiva, but can appear in other regions. It's characterized by a deep red-purple exophytic lesion, usually ulcerated, and its treatment is surgical removal. Peripheral giant cell granuloma. The cause of these are unknown, but it can happen at any age, but is more frequent between the ages of 40 and 60 years of age, and is also more common in women than in men. Its location is on the gingiva, and clinically it's characterized by a deep red exophytic lesion. Its surgical excision is the treatment. Irritation fibroma. This is caused by trauma and is most commonly found on the gingiva, but there are many other oral locations which it can be found. Its clinical features include broad-based pink exophytic lesions, which can be removed surgically. Denture-induced fibrous hyperplasia. The cause of this is an ill-fitting denture or continuously wearing your denture for a long period of time. The location is the vestibule along the denture border, and its clinical features include elongated folds of exophytic tissue surrounding denture flange. Treatment and management include surgical excision or fabricating new dentures. Papillary hyperplasia of the palate. It's caused by constantly wearing of maxillary removable prosthesis. It's located on the hard palate, and clinical features include mucosal surfaces by multiple erythematous papillary projections. Its treatment is surgical removal of the papillary tissue or fabrication of new dentures. Gingival enlargement is caused by a multitude of factors. It can be caused by a response to chronic inflammation. It can be idiopathic. It can be a drug reaction, a hormonal change, or even genetic. The location is the gingiva, and this can be localized or generalized. Its clinical features include the increasing of the bulk of the free gingiva and attached gingiva. The gingiva will have no stippling, and it can be erythemic or it can be normal in color. The treatment and management is a gingivectomy or meticulous oral hygiene. Chronic hyperplastic pulpitis. The cause of this is caries, and it's most common in children and young adults. Its location is the primary or permanent molars, and its clinical features include red or pink nodules protruding from the pulp chamber of the tooth with a large open carious lesion. The treatment is extraction of the tooth or a root canal. Inflammatory periapical lesions. Periapical abscess. The cause is an inflammation of the dental pulp or pre-existing periapical chronic inflammation. The location is the root of primary or permanent teeth, and the clinical features include pain, swelling, fistula, slight extorsion of the tooth. Treatment and management is established drainage. Radiographic features tend to include thickening of the periodontal ligament space and periapical radiolucency. Periapical granuloma. The cause is pulpal inflammation or necrosis, and its location is the root of primary or permanent teeth. Clinical features are asymptomatic, with tooth being sensitive to percussion and a slight extrusion of the tooth. Treatment includes endodontic therapy or extraction. Radiographically, there is a slight thickening of the periodontal ligament space and periodontal radiolucency. Residual cyst. A radicular cyst not removed when the tooth was extracted. The location is the site of extraction, and the treatment and management is surgical removal. Radiographically, there is a radiolucency at the site of tooth extraction. A radicular cyst, also known as a periapical cyst, is caused by a non-vital tooth. The location is the root of the primary or permanent teeth, and most are asymptomatic. The treatment can include endodontic therapy, apicnoectomy, or an extraction and curettage of the extraction site. Radiographically, you'll see a radiolucency associated with the root of the non-vital tooth. Resorption of the tooth, whether it be external or internal, are caused by chronic inflammation or chronic pulpal inflammation. The location is the roots of primary or permanent teeth, or the dental hard tissue within roots or crowns. Clinically, they are asymptomatic, but you might see a pinkish color if the crown is involved. Treatment is usually identification and removal of the cause, a root canal therapy, or extraction. Radiographically, you'll see a blunting of the root apex to severe loss of root substance. Or, if it's internal, you'll see a round to oval radiolucency in the center part of the tooth. Focal sclerosing osteomyelitis is caused by a low-grade chronic infection. The location is the bone adjacent to any tooth, but the mandibular first molar is the most common. Clinically, there are no symptoms, and there is no treatment. Radiographically, the radiopaque area below roots of the tooth are seen. Alveolar osteitis, also known as dry socket, is caused by post-operative complications of tooth extraction. The location is the extraction site, and clinically, there is pain that develops after several days after extraction. Treatment and management include gentle irrigation and insertion of medical dressing.